So speaking of post-refractive patients, let's talk some high-level math. Everybody loves math. Higher order aberrations. The LAL specifically has the unique ability to add depth of focus, and it does that by a triggered mechanism to increase spherical aberration. There's three things that you have to do that. It has to be on the first treatment. You have to be moving in the myopic direction or stay neutral in both meridians in your power cross, and you have to shoot for -50 or more myopic. That will induce a little negative spherical aberration. Seamus, can you talk about how you discuss that, or do you discuss that with patients when you're doing it?
I don't go into like the level of studying it for a test that we would understand it. I do explain that this lens has a specialized feature that I trigger myself at a certain time when we're both ready for it. And that also kind of depends on, how happy is the patient with their vision. A lot of the times, what I'm finding more and more is Dr. Kim's implanted LAL plus is actually pretty good far away and up close at the beginning. And I'm rarely changing these. Like I'm rarely moving past that half diopter mark from the initial implantation on plus. And then I love having that in my back pocket for the standard LAL if somebody wants a little bit more. So I kind of more say that it's a feature that I can turn on or turn off depending on the lens and patient satisfaction, which again, case by case.
Any thoughts, Eva, about that?
So I would say the way I talk about it with my patients has changed from when I started using LAL, and there was not LAL plus, by the way, it was just LAL, to what I say now. So initially, I would talk about blending vision and the non-dominant eye with the LAL. We had an opportunity to create a blend, an offset so that there would be a difference in distance between the eyes, especially someone who's never done monovision and they, again, are feeling a little bit nervous about the concept. But that I could talk about, making their non-dominant eye be more myopic or a little better at near, but I wouldn't have to necessarily make that a dramatic difference between their eyes, because we have a method with the light treatment where we could again bring their eye a little bit further from distance, a little bit better in near, not dramatically, and then have an extended depth of focus that would give them a rich kind of more range, so that they could potentially hit kind of a far near target and intermediate, have that, smoother range of near vision out to distance. So that's what I used to say initially. Again, when I didn't have LAL plus. And I feel like in our patients where I'm not routinely using LAL plus, I'll use an example, a post LASIK patient. So it doesn't even have to be RK or keratoconus, but a post LASIK patient, I will routinely not use LAL plus. I will use LAL in both of their eyes. And that's where I will, kind of discuss that extended depth of focus, that we have the ability to do that. And I will say that that it's typically something that we will go ahead and utilize during our first treatment, because we want to see if we can take advantage of that extended depth quality with treatment number one. And we all know that most of our patients, because I'm aiming for right around plano, even in their non-dominant eye or maybe first minus, they will need in an LAL more than a -50 typically. And so they'll move towards myopia at least that much during their first treatment, and we can take advantage of that extended depth. And I feel like it's worked out really well, Seamus, don't you think, that with LAL patients, and really no complaints that I can think of specifically.
No,
Go ahead, Seamus.
Real quick. Like it's kind of hard to simulate that with the contact, right? Like I know like there's a lot of that trialing, but you can't really simulate what that depth of focus is going to be like in the real world before it happens. But one thing that I've noticed about the outcomes is that once that depth of focus is turned on, some patients are like some patients are still seeing 20/20 through an eye that I'm refracting minus 0.5, minus 0.75.
Mhm.
Some of them are like 20/25. Some of them, like, it's not that giant discrepancy that you would have with like a standard IOL or maybe even LASIK at some point in the past, where you're measuring like minus 150 in plano, where that would give you like a 20/70 eye, 20/60 eye in the distance. It actually functions really, really well at like 20/25, 20/30. Then you give their dominant eye back and they're like, okay, I get what we're doing now. And it's a very, very small difference between the two eyes versus a traditional monovision.
So I was asked to clarify how you do that. So this is only for the LAL, not the LAL plus that used to be, but that's changed. The nomogram has changed. So only LAL. First treatment, you're moving in the myopic direction or staying neutral in both meridians, and it has to be targeted for negative 0.5 or more myopic. So by doing that, you're hitting those three things. You are inducing about a quarter or so, maybe a little bit more added depth of focus. And so when would you maybe consider not doing that? Is there instances where you would be careful about that?
If somebody's happy with things the way they are,
Yeah.
right, and if they can, like, let's say this would be where like a contact lens trial is super helpful. Like, I can give you maybe minus a half and not cross that line, but that also means I'm not able to turn it on. So you have to be like, you have to be happy with where you're at and less than 0.75. But that would be the instance.
And typically I would say, I'm not treating as much. I will say I've treated for about three years, and did quite a bit of treating. I really wanted to understand it as the surgeon. And now routinely our ODs are doing the vast majority of treatments. But when I was treating, I would disable the EDOF with RK patients and pretty difficult corneas. I just thought it was potentially going to create less satisfaction in vision potentially. So I would be very careful and try to keep it very clean and turn it off. But other than that, is there any other reason, Nick, that you tend to turn it off?
That's mainly the reason. I mean, aberrated corneas, post-refractive, especially hyperopic LASIK. I mean, because think about what those eyes already have. They already have negative spherical aberration included in their corneas. So the advantage of adding more, really, we already saw it with those graphs earlier with the LAL plus. Once you hit a certain point, it's kind of counterproductive and it doesn't really help. So same thing with the eye as an optical system as a whole. If you already have a ton of negative SA, why add more? All you're doing is asking for a problem. And that's when you're going to get the glare. That's when you're going to get the halos. That's when you're going to get those complaints that we cannot fix with a pair of glasses, right? Low order aberrations are myopia, astigmatism, prism. That's all low order aberration. Anything you can do in a phoropter is a low order aberration. If you still have optical problems that you can't fix with a pair of glasses, that's a higher order aberration. So those eyes, we don't need to add more noise to the system. Now, the plus, not the LAL plus, but the plus side, the pro to our con, sometimes aberrated corneas have advantage of depth of focus naturally. So RK, right? So the example you mentioned there, never would do the added depth of focus for those patients because those corneas kind of behave like multifocal contact lenses. They have depth of focus, and miraculously, I can have patients who are like way plus and they're still seeing J1. Now, why is that? Because they've got a lot of plus or minus negative spherical aberration. So we don't need to add to that. And those patients are already very happy. The other reason why I wouldn't do it is if somebody can't commit to one eye being dominant. So if they're really wishy-washy, because once you trigger that, you can't undo it. That is something that will always be there. And you can fix that low order aberration wise with a pair of glasses, or you can undo the refractive targeting, but they will always have that negative spherical aberration included. So if they have a little bit of a wishy-washy attitude about it, they're not sure if they want to commit one eye to being reading or not, then I won't do it. We'll just give them maybe a little nudge, but we won't hit that threshold, and there you won't have that negative spherical aberration. On the second treatment, then we can go further. And so that might be a case where we may need two, maybe even three adjustments.